My name's Nish. I'm a radiology registrar at Southampton. I'm going to be talking to you today about the anatomy of the rib cage, so the thoracic inlet, rib cage, intercostal muscles and neurovascular bundles. It's probably something that you haven't had a lot of formal teaching on in medical school, so hopefully today we'll teach you all the things you really need to know about this kind of underrepresentative topic in anatomy. So we're going to start off with a question. So we'll give you 30 seconds to read the question and provide an answer. So the question here is asking which of the following are true ribs, and the answer is option A, ribs 1 to 7. And in the next couple of slides, we'll explain to you why this is correct. So just to start with an overview of the thoracic cage, it's an osteocartilaginous cage which is formed of bones, intercostal spaces and joints. So in terms of the bones, as you can probably work out, the main bones are the thoracic vertebrae, the ribs, of which there are 12 pairs, and the sternum. Between the ribs, there are intercostal spaces, and there are a whole host of various joints that allow the thoracic cage to expand and contract. There are two major openings. So superiorly, there is the superior thoracic aperture, which communicates with the neck, and then inferiorly, there is the inferior thoracic aperture, which communicates with the abdomen. To start off with the sternum, so the sternum is a narrow flat bone which is found in the center, midline of the chest. It's made of 3 parts. So you've got the manubrium, which is this quadrangular bone, which is the superior part, and it articulates with the clavicles and with the first ribs, and also the junction of the second rib. Then you've got the body of the sternum, which is the longest part, and it articulates with the junction of the second rib and the third to seventh ribs. And then the xiphoid process, which is this small process that extends inferiorly at the bottom. Just a overview of the ribs. So they're curved flat bones which make up most of the thoracic cage. As I said before, there are 12 pairs of them, so there are 24 in total, and there are 2 ways of classifying them. So one way of doing it is by their articulations, and if you do it this way, they can be classified as true, false or floating ribs, or you can classify them by structure, and in that system you'd call them either typical or atypical ribs, and we will discuss the definitions of these things in later slides. The whole point of the thoracic cage is twofold. So first of all, it protects the contents of the thorax, and it also allows for expansion and contraction to aid respiration. So talking of true, false and floating ribs, so the true ribs are considered ribs 1 to 7, and they're considered true because they have articulations with the sternum via costal cartilage. Ribs 8 to 10 are considered false ribs, and that's because they don't each have their own articulation with the sternum. Instead, their sternal cartilage merge with the 7th rib sternal cartilage and have a single articulation with the sternum. And then ribs 11 to 12 are floating ribs because they have no articulation with the sternum whatsoever. So they end kind of laterally and they don't have any sternal cartilage at all. So the costal cartilage is highlighted in yellow on this slide. It's a type of hyaline cartilage, and it forms the costochondral junction, which is the articulation of the sternal ends of the ribs and the costal cartilage. There are 10 pairs which join to the top 10 ribs. And as I said before, the 11th and 12th ribs don't have any costal cartilage. They have very little movement in normal life, but they can move. So, for example, if you do CPR on a patient, often it's kind of the costal cartilage and the costochondral joints that are moving when you compress the chest. But obviously, that's not kind of a normal thing. That's not normal physiology for a patient. So this is question 2. So again, we'll give you 30 seconds to read the question and answer it. Okay, so this question is asking which of the following ribs are atypical, and the answer is option C, so the 1st, 2nd, 10th, 11th and 12th ribs. So trying to understand what makes up a typical and an atypical rib, the easiest thing to do is to define what is a typical rib, and then anything that doesn't fit that should be considered atypical. So a typical rib has a head which is wedge-shaped and has 2 articular facets, one superiorly and one inferiorly, and then it has a longish neck, and then this neck body junction where you've got another tubercle, which is the articulation with the transverse process of the corresponding thoracic vertebral body or vertebra, and then it's got a body which on its inferior surface has a costal groove. Just to go into the detail of a typical rib a little bit more, so the purple highlighted area on this diagram demonstrates the demifacet, which articulates with the rib above the named rib, and then the blue one is the demifacet which articulates with the vertebra at the level of the named rib. So for example, if we said this is the 3rd rib, then the blue facet articulates with T3, while the purple facet articulates with T2. And then again, the green area is the tubercle, which articulates with the transverse process. And again, if we called this the 3rd rib, then this would be the transverse process of T3. The yellow area is a non-articulating tubercle, where you get attachment of various ligaments which help support the position of the rib and the thoracic cage in general. And then the red area is the costal groove, where you've got your neurovascular bundle, which runs in that groove. So talking of atypical ribs, start off with the 1st rib. So the head of the 1st rib is unusual because it's slightly smaller and more rounded, and it only has 1 articular facet. So it only articulates with T1, and it doesn't articulate with C7. And the neck is more narrow and rounded than a normal neck on another rib. The undersurface is also different because it doesn't have a costal groove. And then the upper surface has a few additional things that most ribs don't have. So first of all, it's got these 2 grooves here where the subclavian vessels run. So you've got the subclavian groove where the subclavian artery is, and then the subclavian groove for the groove for the subclavian vein just next to it. In between these 2 grooves, you've got this little tubercle, which is where the scalene anterior inserts. And then posterior to the subclavian groove, you've got this other roughened area where the scalene medius or middle scalene attaches. And you also have another attachment point anterolaterally, which is where your serratus anterior originates. Overall, it's also the shortest rib and has the most curve. The 2nd rib, it's got 2 facets, so more like a typical rib, but it's got a much shorter costal groove inferiorly, and it doesn't really exist as it comes anteriorly. And then the upper surface has this roughened area where this, another, again, part of the serratus anterior originates. The 10th rib is atypical because it only has one facet. So again, it only articulates with T10 and not with T9. The 11th rib only has one facet. It doesn't have a neck or a tubercle, and it's slightly more pointed and has a shallower costal groove. And this is a similar story for the 12th rib, and it's also shorter than the 11th. And if you remember, ribs 11 and 12 are floating, so they're much shorter than other ribs are. And this is just a brief overview of the 5 atypical ribs that I've just discussed. So this is question 3. So again, we'll give you 30 seconds for this. Okay, so the answer here is option D. So one of the characteristic features of thoracic vertebrae are that they have demifacets on each side of the vertebral body. So looking in more detail at the thoracic vertebra, there are 12 of them, so T1 to T12, which match the number of ribs that you have. Their characteristic features are that they have costal facets, which are found on the transverse processes, which articulate with the tubercles of the ribs. If you remember, I showed you what the tubercles of the ribs look like earlier. And then they also have demifacets on each side of the vertebral body, which articulate with the heads of the vertebral bodies. And most of them articulate with 2 ribs, if you remember. The body itself is slightly heart-shaped. Hopefully, you can, if you squint, you can see that this kind of looks like an upside-down love heart. They're smaller than lumbar vertebral bodies. Lumbar vertebral bodies are the biggest in the spine, and they're longer than the cervical vertebral bodies. And then their spinous processes are long, and they tend to slant inferiorly compared to, say, for example, lumbar vertebral bodies, lumbar spinous processes, which tend to be a little bit more horizontal. Just to cover their articulations again, so we've got the costovertebral joint, which is between the head and the vertebral body. And as I said, you've got 2 of them. They articulate with the rib of that level and the rib above, or sorry, the rib below. And then you've got the costotransverse joint, which is the articulation between the tubercle of the rib and the transverse process. This is question 4. Okay, so the question asks, which of these structures is the lateral border of the thoracic inlet? And the answer here is the first pair of ribs. So the thoracic inlet, which is also called the superior thoracic aperture, is the superior opening of the thoracic cage. It connects to the root of the neck, and it allows passage of structures that are in the neck into the thorax. So they include arteries, veins, nerves, the esophagus, the trachea, amongst other things. Its boundaries are posteriorly is the T1 vertebral body, and then laterally is the first rib on each side, and anteriorly is the superior border of the manubrium. Obviously, it's a very complex region around the root of the neck, and it has relationships with other structures. So you've got the clavicle, which articulates with part of the manubrium anteriorly, and it forms part of your anterior and kind of anterolateral border of your superior thoracic aperture. Superiorly, as I said, you've got the root of the neck. And then an important structure to know about, which comes out superolaterally, is the brachial plexus. So the brachial plexus it is formed of the roots of C5 to T1, and it emerges between the anterior and middle scalene muscles, superior to the first rib, and then it descends obliquely towards your axilla. And you can get impingement either in kind of semi-normal physiology by the scalene muscles, which obviously goes between, or if you have some kind of mass lesion or tumor, either coming from the apex of the chest or from the neck itself, which can compress the brachial plexus. The thoracic outlet, or the inferior thoracic aperture, is the inferior opening of the thoracic cage. It forms the connection with the abdomen below it, and it's completely closed off by the diaphragm. Its borders are the T12 vertebral body posteriorly, and then laterally is formed by the 12th rib, and then when the 12th rib stops, it's formed by the 11th rib. And then as you come anteriorly, the border is the costal cartilage, the fused costal cartilage from ribs 7 to 10. And then very anteriorly, it's the xiphosternum. It's obviously much larger than the thoracic inlet. So as I said, the thoracic outlet, or the inferior thoracic aperture, is completely closed off by the diaphragm. But obviously things need to get between the thorax and the abdomen. So there are 3 main diaphragmatic hiatuses through which structures pass. So the diaphragm itself is skeletal muscle, so it's under voluntary control, and is formed from 2 crosses. So you've got the left cross and the right cross, and as I said, there are 3 hiatuses which the fibers of the diaphragm wrap around. So the first hiatus is the caval hiatus, and it occurs at roughly T8, and it transmits the inferior vena cava and the right phrenic nerve. And a good way to remember what level the caval hiatus is at is if you spell out vena cava, it has 8 letters, which matches with the fact that it goes through passes through at T8. The next one is the esophageal hiatus, which passes at T10, and it transmits the esophagus, both vagal nerves, and then branches of the left gastric artery and vein. And a good way to remember this is if you spell esophagus in the British way, it's got 10 letters, which matches with T10. And then the third hiatus is the aortic hiatus, which passes at T12. And it's also the most posterior hiatus. It transmits the aorta, thoracic duct, and azygos vein. Again, if you spell out, or if you look at the number of letters in aortic hiatus, it contains 12, which matches with T12. This is question 5. So the question is asking, what is the order of the neurovascular bundle from superior to inferior in the intercostal space? And the answer is vein, artery, and nerves, option C. So just to go into a bit more detail about the intercostal space. So it's the space between 2 ribs. So you have 11 spaces because you've got 12 ribs. So there is no intercostal space below the 12th rib, because there is no other rib beyond the 12th rib. And they're numbered according to which rib forms the superior border. They contain the primary neurovascular bundle is contained under the inferior border of the rib above. And as we said, it's structured as vein, artery, and nerve. And there is a collateral bundle, which is found just above the rib below, where the order is reversed, so it's nerve, artery, and vein. But the collateral bundle is far less important than the superior bundle, or the main bundle. Other structures contained within the intercostal space are things like lymph nodes, but they're often very tiny and not clinically significant. The spaces themselves are, or the space itself is bordered by muscle. So you've got 3 muscle layers within the intercostal spaces. So the most superficial one is called the external intercostal muscle. And then just deep to that, you've got the internal intercostal muscle. And then deep to the internal intercostal muscle is where your neurovascular bundles are. And then your deepest muscle layer is called your innermost intercostal muscle. So your bundles sit between the internal and your innermost intercostal muscles. So as I said, your neurovascular bundles are ordered vein, artery, and nerve. And the main one, which is the superior one, sits in the costal groove. So, and the costal groove acts as a protection for the bundle. Direct penetration through the intercostal space shouldn't hit the superior vessels or bundles because they're protected by the groove itself. The collateral bundle is not as important, and if you're going to do something which involves you going through the intercostal space, normally you don't particularly worry about hitting the collateral bundles. And for example, if you want to put a needle through the intercostal space, for example, to put in a chest drain or something like that, you would normally aim to go just above the inferior rib in the space, because what you want to do is completely avoid the superior bundle, which has much bigger artery and much bigger vein and can bleed a lot worse than if you hit the collateral bundle. So the intercostal, so the arterial and the venous supply or a structure of the intercostal bundles is quite complicated because of the fact that there are so many of them. But just to give you a general overview, you can divide your intercostal veins into 2 groups. So you've got your anterior and your posterior, and they anastomose together laterally. So your anterior intercostal veins drain into your internal thoracic vein, which is also called your internal mammary vein. The upper ones go to the internal thoracic, and the lower ones go into your musculophrenic veins. Your musculophrenic and your internal thoracic are continuations of the same vein. So they're basically anastomoses. And then posteriorly, it's a little bit more complicated. So your brachiocephalic vein drains your first intercostal space. Your second to fourth intercostal spaces drain into your superior intercostal veins. And then your 5th to 11th do all sorts of things, depends on which side. But they drain either into your azygous vein, your accessory hemiazygous vein, or your hemiazygous vein, the latter 2 if they're on the left. This is question 6. So the question asks, how many of the intercostal arteries arrive directly from the thoracic aorta? And the answer is the lower 9. So if you thought that the structure of the veins was complicated, the structure of the intercostal arteries is even more complicated. So your upper 9 intercostal spaces have both an anterior and a posterior intercostal artery, which again anastomose laterally. Your 10th and 11th only have posterior. And this is because if you remember your 11th and 12th ribs, which, pardon me, form which form your 10th and 11th intercostal spaces, they don't attach anteriorly, so they're only present posteriorly. So your internal thoracic artery or internal mammary artery give rise to your anterior first 6 intercostal arteries, and then your musculophrenic, which again is a continuation of your internal thoracic artery, give rise to your 8th and 9th. Sorry, it should be 1 to 7 for the internal thoracic, and then your musculophrenic gives rise to your 8th and 9th. Your highest intercostal artery gives rise to the 1st and 2nd posterior intercostal arteries, and then the aorta gives rise to the 11th to the 3rd to 11th posterior artery. So these arteries come directly off the aorta laterally. And this is a schematic explanation of that. So you've got your thoracic aorta, which gives rise to your subclavian artery. So we're not concerning ourselves with side here. So let's just say subclavian artery. But if it was the right side, then it would be via the brachiocephalic first. And then your subclavian artery gives rise to this tiny branch called the costocervical trunk, which then gives rise to your highest or supreme intercostal artery, which supplies the 1st and 2nd posterior intercostal arteries. Your subclavian artery also gives off your internal thoracic artery, which goes anteriorly. It goes behind your sternum, inside your thoracic cage, and then it gives off your 1st to 7th, this should say, anterior intercostal arteries, and then it is a continuation or an anastomosis with the musculophrenic artery, which then gives off the 8th and 9th anterior intercostal spaces. And then as the thoracic aorta becomes the descending thoracic aorta, it gives off the lower 9 intercostal arteries on both sides. So this is question 7. So we've got another bit of a split vote here. So the question is basically which of the dermatomes covers both parts of the chest and the arms. So 35% have said T1, 35% have said T4, and then we've got a smattering that say T6, T8 and T12. And the answer here is T1. So the dermatomes are covered by the intercostal nerves, which are part of your somatic nervous system. Your intercostal nerves arise from the anterior rami of your thoracic spinal nerves between T1 and T11. And they can have quite variable supply, but your 1st and 2nd normally do supply your thorax and part of your upper limb, your 1st more than your 2nd in terms of your upper limb. And then 2nd to 6th cover your thorax, and then your 7th to 11th tend to come more inferiorly as they go anterior, and they cover your thorax, lower thorax and part of your abdomen. They're mixed nerves, so they contain both sensory and motor innervation, so they innervate your thoracic muscles as well. So your 1st intercostal nerve, it bifurcates at the neck of the 1st rib and has 2 branches. So the superior branch forms part of your brachial plexus. So if you remember, your brachial plexus is C5 to T1. So your superior branch is that T1 bit, and then your inferior branch becomes your first intercostal nerve proper. Your nerves 2 to 6, so the anterior rami directly enter the intercostal spaces, and they pass through the costal groove, as we said, in between the inner and innermost intercostal muscles. They give off the lateral cutaneous branches around the kind of mid-axillary or armpit regions. And then in the anterior chest, they give off their anterior cutaneous branches. They also have muscular branches, as I said, which innervate your intercostal muscles and your subcostal, and then your other accessory muscles of respiration. They also supply the periosteum to the rib, so they give sensation of rib pain. Your 7th to 11th nerves, again, they enter your costal grooves, in the intercostal spaces, and they supply the skin and the muscles of the region, as well as the parietal peritoneum and the abdominal skin as well. And I'm sure you've all seen these dermatome maps before, but they give you a rough idea about which levels which areas of the body each level of anterior rami supply. And T1 often supplies kind of the medial part of your upper limb, around kind of your armpit or your medial part of your bicep, as well as part of your back. So that's why this was the correct answer in that question. Question 8. So we've got 48% of people have gone for that there are 11 pairs of intercostal muscles, and you would be correct. So basically there are the same number of intercostal muscles as you've got intercostal spaces. So you've got 11 spaces, so you must have 11 muscles. So as I said before, there are 3 groups of muscles. There's the external, internal, and innermost intercostal muscles, and they all support respiration, and they all support normal respiration. So your external intercostal muscle is your most superficial. It runs from the inferior border of the rib above to the superior border of the rib below, and its fibers run inferomedially, so they come towards the midline of the chest. As we said, they are supplied by your intercostal nerves, and the action of the external intercostal muscle is to elevate the ribs during forced inspiration, and that increases the volume of the thoracic cage. In contrast, your internal intercostal muscle also runs from the superior border of the rib above to the inferior border of the rib below, but in this time their fibers run perpendicular to the external, so they run inferolaterally, supplied in exactly the same way, but when they contract, they depress the ribs, and they by doing that, they make the thoracic cage smaller, so they force air out of the thoracic cage. And then finally, you've got your innermost intercostal muscles, and they are the deepest muscle. Again, they tend to pass inframedially. In this diagram, they kind of seem to be a bit more just vertical. Innervated exactly the same way, but again, they are a muscle of expiration, so they depress the ribs and they make the thoracic cage smaller. So question 9 is moving on to slightly more obscure muscles that you may not have heard about, but see what you think. So we'll just see what the answers were. So again, this one's really split everyone. So 30% of people have gone with C, serratus posterior superior. 25% have said innermost intercostal. 20% have said either transversus thoracis or serratus posterior inferior. So the answer is what the majority of you said, which is C, but we'll cover all these muscles in brief detail now. I must say I'd never heard of any of these when I was a medical student. I think they're quite small print, so hopefully having heard of them today, it might be as much as you possibly need to know about them ever. But let's just go through them. So there are several groups of muscles that support respiration, and these include some of the muscles that we've already described, such as transversus thoracis, the subcostal muscles levator, levatorus costarum, and the serratus posterior, which has the inferior and the superior parts to it. So starting with the transversus thoracis, it's part of your intrinsic muscles of your chest wall, and basically they arise from the posterior surfaces of your 2nd to 6th ribs, and then they run inframedially and attach to the back of your sternum. And what it does is it depresses the ribs during forced expiration, so it helps you expire, as well as supporting the intercostal spaces and the thoracic cage. And as with all these muscles, they're innervated by the intercostal nerves. So the subcostal muscles, they originate from the undersurface, the inferior surface of the lower ribs, near the angle of the ribs, and they attach to the superior border a couple of ribs below. So they're similar to your innermost intercostal muscles, but your innermost intercostal muscles are just between one rib and the one below, whereas these ones span a few ribs. And again, they assist with respiration and support the cage and the intercostal spaces. Your levatores costarum, there are 12 of them. They're triangular shaped muscles, and you find them on the posterior aspect of the vertebral body, so they're very posterior, and they descend adjacent to the spine, and they span the thoracic region from T7 to T12, and they help elevate the ribs. And actually, this is one muscle which is not innervated by your intercostal muscles, because they're posterior. They actually come from the posterior rami of your T1 to 12 vertebrae. your serratus posterior, so the superior bit, they originate from the spinous process, just adjacent to your spinous processes from C7 to T1, and then they insert adjacent to the superior borders of your second to fifth ribs. So if you imagine these muscles contract, what they do is they elevate the ribs, so they make your thoracic cage bigger. So they're useful for forced inspiration. And then your serratus posterior inferior, they originate from adjacent to the spinous processes of T11 to L2, and then they run upwards and they attach to the posterior surfaces of your 9th to 12th ribs. And imagine if these contract, they pull the ribs down, so that's for forced expiration. And that's our whistle-stop tour of the thoracic cage.